So what are the concerns? What criteria, that's the word I'm looking for, do you need to meet in order to reduce a injury, a fracture or a dislocation? Exactly. So your criteria for this, for actually reducing an injury, would be a loss of pulse, cyanosis, or a purple discoloration, hey Joni, to the extremity, to distal to the injury, or even potentially like the bone protruding through the skin. There's a possibility that you may want to reduce that if there is a question of being able to control bleeding. Okay? I think there's one regarding the Parkland formula and how much of the fluid you need to administer within the first 8 hours, but there is no actual calculation of body surface area, rule of nines, etc. You're welcome. Mostly because I hate those questions, so I wouldn't make them on the test. Cool. All right, so any other questions, thoughts, concerns before we get started? I'm going to do 2 patient scenarios with you. This is where we could talk about some of the, some of the protocols. Yeah, I'm going to use City Remax. We use the ones that are currently up on the City Remax site, which are from April 2019. Just because when you guys actually do get onto the ALS ambulance, this is what's going to be what you're using for the next 3 months. Hi, Roger. It's supposed to change to the collaborative protocols in January. If it does, I'll be impressed, because they have to now, like, in-service everyone on the new protocols. However, there is not, from my, like, brief perusal through, it does not appear to be like a significant change between one and the other. The biggest change is really how it's formatted, where the current protocols are like listed. Oh, you're an ALS provider, here's your ALS protocols. Whereas the new collaborative or unified protocols is, here's your CFR. Are you not a more than a CFR? Cool, stop here. Are you a BLS provider? Keep going. Cool, you're not an ALS provider? Stop here. Are you an AEMT? Here's the things you can do. So it's not split up the same way. It's really, in the grand scheme of things, more of a formatting change than anything else. At the real root of the protocols, I don't really see a lot of change. The only thing that you do get now is to reduce a dislocated knee and to re-implant an avulsed tooth. I wouldn't do it. I'm gonna put my hands in somebody's mouth. For which protocol? Because I do believe it's actually... Hold on. I'll let you know. Shock. For cardiogenic shock, I do believe that dopamine is standing protocol. Yes. So in the current 504B cardiogenic shock, dopamine is still standing protocol. It is standing protocol with norepinephrine. They are used interchangeably. Or you can also use push epi. Push epi is great for septic patients. Norepinephrine is better for septic patients. Dopamine, not the best. In terms of like patient outcomes, norepi has been found to just kind of be a little better because basically it's not dose dependent, and it doesn't affect the kidneys as much as dopamine does. And when you are in a shock state, the biggest concern is making sure that the kidneys are doing what they're supposed to do. So I think that that's the primary reason that norepi has better patient outcomes. And I think people also are like, less math. So good mention though. All right, cool. So let me know. I'm going to share the screen. You should be seeing nothing apparently. Why are we not? That's rude. What do you guys see? All right, good. Just making sure that was doing what it was supposed to do. All right, cool. Let's start with this one. All right. EMS is called to the scene of an elderly female complaining of feeling weak. Upon arrival, a 78-year-old female is found lying in bed, pale, diaphoretic, and drowsy. Family states the patient had gone to the cardiologist yesterday, who prescribed her a new medication that she took for the very first time this morning. After taking the medication, the patient started feeling off with weakness, nausea, and dizziness. Your patient's only medical history is hypertension. She has just started labetalol, and she has no allergies. Current vitals are 98/40. Respiration's 18. Pulse is 40. And SpO2 is 92% on room air. So, let's start with, come on, pen. And here's you have your 3 lead and you have your 12 lead below. I'm going to move that up. Oh, I won't move that up a little bit. Hold on. Move that up a little bit so you can see. I know it's small, but bear with me. All right, so first things first. What are your differential diagnoses for this young lady? Okay. What else? What other? Yeah, no. Come on, everybody. Maybe. Hold on. Son of a... Hold on, I'm working on figuring out the Zoom. If I were to Zoom... Oh, thank you. Ow. Roger. Alright, there you go. The dog helped too. You're welcome. Alright. So we have a current differential diagnosis is adverse drug reaction. What else could it be? Oh, what's one of the most obvious ones? Like her pulse is 40. Her pulse is 40. All right, she's close. So let's find. Here we go. This one. You've got one little box, 2, 3, 4. Borderline. So I call it borderline first degree. What's a more bigger, I guess, concern? You're thinking too complicated. How about symptomatic bradycardia? What can cause symptomatic bradycardia? Chronic hypertension. Okay, so she was just treated. They just started treating her hypertension. What else? Yep. That's her new medication. What kind of medication's labetalol? Beta blocker. How about a beta blocker overdose? Take it a step further than drug adverse. One more that should be high on your list. Ow, dog.
Hey, come here.
Yeah, hold on. Let me magic dog unplug my computer. Y'all getting real demanding, you know that? There we go. Okay. You're welcome. All right, this one, it's a really easy one. I'm not trying to stump you on what the last differential diagnosis could be. You have a female patient with a history of hypertension. She's 78 years old, long history of hypertension. She just got on a beta blocker. Maybe. You should always suspect that your patient might be having some sort of NSTEMI, some sort of cardiac event, right? That's why you're doing the 12 lead, right? This is why we did that. What's up? Oh, absolutely. Absolutely. The official stance, as per the AHA, is any sort of chest pain should be considered a cardiac event, period, no matter what. When you have your atypical patients, right, you have your diabetics, your chronic hypertensive, your female patients, elderly patients, you should also kind of consider, even if they aren't presenting with chest pain, but they're presenting with weakness and fatigue or something like that, also consider that a possibility does exist that it could be a cardiac event as well. Yep, they'll check the troponins. If it's over, I think, 0.1, it's considered a cardiac event, and they'll call it as an NSTEMI. Good questions. All right, let's go back to sharing real quick. So now that we have some differential diagnoses in place, which magically disappeared, put them back real quick. Come here, my little pen. Right, so we had symptomatic bradycardia. We had a cardiac event. I'm going to put adverse drug reaction, beta blocker overdose. Okay, so those are the 4 that we're working with right now. Easiest one that we could kind of rule in or out what we can do, like for the patient in terms of treatment, is your cardiac event, right? What is your protocol for a patient having a cardiac event? Mm-hmm. Wait, no. That's this one. That's symptomatic bradycardia. Just... Perfect. O2. Mm-hmm. I'll put it, okay, we'll put it down. Nitro given good vitals. Or better vitals. Okay. What else? There's one other thing, at least one other thing that I would consider for this patient, based on their vitals. What's that? Aspirin. Okay, one other thing. Wait, no, we're still in cardiac event. What's that, Ben? IV and fluids, beautiful. And not to like break your hearts or anything, but this right here, these 5 things, sometimes we also call it, I'm going to put it over here real quick, vomit, vitals, oxygen, monitor, IV, transport. That is 95% of your jobs right there. Okay. Almost all of your cardiac events, right? You're going to give them oxygen, position of comfort, maybe a little nitro, aspirin, IV, and you're transporting. Everyone gets really excited, like, yes, it's a STEMI, we're going to go do something. And you're like, here's some aspirin. Here, take this, please, thank you. And that's it. Like, that's all you do. You go to the hospital and go, okay, it got worse, or okay, the nitro made it better, and, we're going to go to chest pain, we're going to go direct to cath, and that's it. One of the most essential protocols that you'll work with, but also sort of one of the most boring. All right, now Joe is itching for symptomatic bradycardia, so let me change my pen color. All right, symptomatic bradycardia, so what are we going to do here? Okay, would you IV and fluid this? Yes, to both. Okay, how much how much is your fluid challenge? I'll tone that down. That's a lot. No. 500's a lot. 250. I'd say 250 is probably your max. If you look, so let me bring up your cardiogenic shock. Bloop. So your cardiogenic shock protocol has, no, that's drug my therapy. Cardiogenic shock, 250 milliliter bolus of normal saline. Repeat once for a maximum total dose of 500. So in the event of cardiogenic shock, you're only going to give them max of 500. So it's a good rule of thumb that if your patient is dealing with a cardiac event, to kind of go slow with the fluids, right? Okay, so 250 at a time is a good starting point. You don't have to go completely wild and crazy. Especially 98/40, that's sort of borderline, right? You're not gonna, be a little, you won't be extra aggressive. You're not gonna flush her full of fluid and hope for the best. Now, going back to bradycardia, if I could spell. All right. Brady dysrhythmia is complete heart block. Okay. If you have a patient who has a ventricular rate of less than 60. Okay, check. And signs of decompensated shock. So now what are your signs of decompensated shock? Okay, so you have hypotension, which, you know, hypertension is like capital H. Personally, my little shorthand is a baby H for hypotension, in case anyone's not sure what that means. So hypotension. Okay, what else? Dizziness. Okay. Okay, good. Okay. Right? So this is a patient who is going to need some level, right, of treatment. Now, would you give her atropine, right? Your first step here is atropine. If you're treating her for symptomatic bradycardia, would you give her the atropine? Okay, good. Good. Not to burst your bubble, but AHA just in the 2020 update increased the administered dose of atropine up to 1 milligram instead of 0.5. 0.5 is a relatively small dose of atropine. Atropine is great, but it doesn't do much. Okay, so we've treated this patient, we've given her this 0.5 of atropine, and your EKG looks identical. What are you going to do now? Okay, good. Toxicity. The toxicity of the city.
Of the city.
Of the city. Thank you for the 3 people who understood that. Right, so it's maybe a toxicity. Would you pace her? Who said yes? Why are you going to pace her, Ben? Okay. Okay, so this little delightful asterisk here. All right, so you get one dose of atropine before you have to call. Okay, so either way, if you want to give her more, so say you gave her atropine, you gave her 0.5 of the atropine and her heart rate came up a little bit. You're like, ooh, okay, we can play here. Either way, to do anything else in this protocol with this patient who is conscious and awake, you are calling medical control because they don't want you to go electrocuting this little old lady without proper sedation. So, before we go further, what are our options? Where's my eraser? What are our options for sedation for whatchamacallit? TCP, for transcutaneous pacing. Okay, how much? No, it's okay. How much is your midazolam? So in this situation, they won't let you give midazolam IM. You can only give it IV. I do believe that diazepam is 2 to 5. No one has diazepam anymore, so we can cross that out. Now, Ashley, I heard you say etomidate. Okay, so perfect. Thank you. Thank you for pointing that out. Etomidate is if you're going to do synchronized cardioversion only, because it's so short acting. So basically, you would probably get about 3 or 4 pacing electrocutions in there before the patients would be like, this hurts a lot now. So your ideal for this patient would be ultimately midazolam, since I really don't know anyone who actually carries diazepam anymore. Okay. Now, you give your presentation to the physician. Someone give me the patient presentation. Someone other than Joe, because I know Joe's got to have this down. Someone other than Joe, give me the patient presentation that you're going to give to medical control. All right, you call ring, ring, hi, medical control. And trust. Go ahead, Jody. Okay. Yeah, definitely. They're going to be like, all right, what's your vital signs? Would you tell them about her medication change? Okay. Good. Because if you do happen to tell this physician about the patient's medication change, he's going to go, before you pace her, I want you to give 2 milligrams. Can you guys still see the screen? Okay. You're going to give 2 milligrams of glucagon. You're going to give her 1 gram of calcium. And you're going to give her dopamine. If that doesn't work, call me back. You're going to go, okay. So calcium, so the thought is, the whole thought process behind why we give calcium, there's two different reasons why we give calcium for beta blocker overdoses. One, it's to help try to improve the contractility of the heart. The other is because, and none of this has really been fully scientifically proven, but when you have like this cell, right? So imagine this is the cardiac cell. It has a receptor for the beta blocker, right? That's a beta blocker. And then right next door is a calcium channel blocker. So the thought is that if you start to stimulate the calcium channel, you will kind of override the beta blocker because they're like kind of so similar and so close together. But yeah, there's really not a lot of solid evidence as to why we do calcium. I'm watching a total disaster. Glucagon is a known antidote for beta blockers. Yeah. Yeah, you really do need a smidgen more. But it does start the process. I guess not the concern, but the idea is that you get the whole ball rolling. The dopamine's going to, the glucagon's going to kind of tamper the effect. The calcium might help the heartbeat better, and then the dopamine's definitely going to help the heartbeat better. And by the time you get to the hospital, they will either give them more glucagon or, go from there. Yes. No, we can't give it. Only if they're unresponsive. No, I wasn't shaking my head at you. I was shaking my head at Kyle because he's asking me where stuff is in the kitchen. And I'm like, we don't have that. We don't have red wine vinegar. We have regular vinegar.
Are we peasants?
Yes, we are peasants. So that's that moral of the story. Now, hold on. Zach, it's weird. I can see the reflection of the Zoom in your phone case. Sure. You're close. You're super close. You have like an hour. You're fine. It's true. All right. Yep. Hooligans. All right. So we talked about that. We talked about the drug overdose. Good. If this patient said, hey, I just woke up and I feel really crappy, and you put him on the monitor and the heart rate's 40, and you're like, do you work out, bro? And they're like, nah, then, going towards a transcutaneous pacing might be your solution, especially if that vital sign, that blood pressure starts to drop, okay? The 98/40 is kind of in that permissive range where you can be like, if I drive really fast, like Danny, I can get to the hospital in 2 minutes and we'll be okay. We'll let the cardiologists deal with it. In the event that you are not that close to the hospital, you might want to call and start pacing. Pro tip, the midazolam does not work great in terms of sedating the patient for whatchamacallit, transcutaneous pacing. All right. Before we move on to the next scenario, any questions, concerns, discussions that you want to have about that? Mm-hmm. Well, I think it's kind of a little bit of when do you pull out the big guns? Because we only have so many options. And granted, most of those options are pretty definitive and pretty much what they do in the hospital anyway. But do you want to go to the big guns in a knife fight, or do you want to try to machete it first? Exactly. So if I gave you that same scenario, okay, so say for example, you have a 35-year-old male who you walk in, and this is my other big bradycardia story or patient contact that I've had. You walk in and you go, hey, and he's like, hey, I don't feel good. And you're like, all right, dude, like what's going on? He's like, I don't know, just I wasn't feeling right today. You put him on the monitor and he's got a heart rate of 30. And you're like, let's get a blood pressure. And his blood pressure is 90/40. You go to get him into the stair chair to get him out of the, and he's kind of he's not sitting down, he's not laying down, but he's not sitting all the way up either. And you sit him in the stair chair and his heart rate goes down to 20. Will you pull the big guns out for him? Yeah, because are you going to, so let's add an extra addition of twistiness. He's on the 4th floor of a walk-up. Are you going to be able to get him down to the ambulance in one piece? The answer to that was no. He got paced. And this is why I know that midazolam doesn't work great, because he was going ow, 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 ow the entire way to the hospital. This dude also weighed he was one of those solid bodybuilders types at about 280, and I was like, why you live on the 4th floor, bro? That's not cool. Not a single elevator to be found. It was me and my partner. I was working with Frankie Filoramo. And then you have 280 pounds of dude on a scoop with a 30-pound life pack. And your 30-pound backpack and the oxygen bag, which I think we had the wife carry, and she's holding it like this. And I'm like, you're going to be okay. She's like, what's wrong? I'm like, don't worry, we got him. He's going, ow, ow, all the way down the stairs. And you get to and it wasn't like a nice straight set, and then you keep going. No, it was like you get to a landing, and you had to turn, and then you had to go down another half, and then you had to turn. Pivot, yes, pivot. Because we couldn't sit him up. Every time we sat him up, his heart rate would go into the 19s. And I was like, I've never seen a heart rate that low. And Zach, this is for you. So the 78-year-old lady who played labetalol the first time, she was in the smack dab in the middle of a king-sized bed. And I was working with Biscuit, and Biscuit hopped on the bed and went, boop, 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 stuck an EJ in her, went boop, 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 back off the other side of the bed, and was like, all right, we can go now. And I was like, you could have brought her with you. Like, Biscuit. But working with Biscuit is an adventure. Yep. Paragod, yes, he does it. He occasionally walks on water. You, as a paramedic, you can start an IV in more places than any other medical professional who does not need permission, aka a doctor. So nurses have to ask to do an IV anywhere other than like the AC or the hand. Or sorry, from the shoulder down, because there's some nurses. If you ever go to Jamaica ER and you ever work with Bobby Serena, he's gonna show you a trick. Hold on, makeup. Joni, next time you see Bobby, be like, show me that trick. You put it the VCB real high, because there's a vein like right here. And if you have like somebody who's got really crap arm veins or really obese, especially like older women, you get it up high, and there's a vein that kind of pops like right here. Gets it every time. You actually should hip bump your preceptor out of the way. And if you have the opportunity for an EJ and you don't do it, you actually might be failed by your preceptor. It can be like, why didn't you try? Other highly useful locations for IVs, feet. A lot of people are weird about feet. Personally, I love starting IVs in the feet. It's just like starting it in the hand. You just have to kind of be cautious. Ankles are also pretty good, especially like younger people who have a lot of like nice vasculature. No. Kyle's being inappropriate. Yo. Yeah, I would say the biggest obstacle to getting an EJ successfully is honestly the jaw. So if you can get the patient's head kind of up and out of the way so you have access to the neck, you'll be golden. Patients who have JVD, easiest EJ you'll ever get. Especially they're like the APE or whatever, and you're like, I got this! Like across the room, like throwing it in like a dart. You also might not get flashback, okay? EJs, because they're such a high pressure vessel, will not necessarily give you flashback into the catheter. You have to have faith that you are in the right location. But if you want, like Kyle's giving me like the don't forget. But if you press on the patient's abdomen, like right in their liver, it will actually inflate the jugular. You can see it. You can actually see it. Ready? Hold on. Stop doing it now. You can kind of see the. No. Hold on.
I'll come help.
Don't come help. No, do not. I did abs the other day. Don't come help.
I'll come help.
Hold on. Let me get closer to the. Alright, go ahead. Ow! Can you see the. You can kind of see a pop. You can kind of see a pop up. In a patient who's at the appropriate, like, 45-degree angle, it'll be a lot better. A lot more noticeable. No, we had Dr. Hedge. Dr. Hedge is one of the most conservative yet adorable medical control doctors. We were also kind of around the corner from Jamaica, and he was like, just transport. She is okay. Just go to the hospital. And we're like, damn it. We want to. He's like, no, just go to the hospital. They will do it at the hospital. And you're like, this face happens a lot if you ever ride with me. You can't see it now because of the mask, but I do this a lot. And you'll know by the eyebrows. Labetalol. Labetalol is one of the more potent beta blockers too. So I don't know why this lady, I mean, when we had gotten the history from the family, they were like, yeah, she's never been diagnosed with anything before. She just got diagnosed with hypertension. I was like, they put her on labetalol? They're like, yeah. I'm like, you put, like, that's one of those step up drugs. Like, hi, you've had hypertension for 30 years. We started you out at a nice, cute starter beta blocker we call carvedilol. Then maybe we move up to metoprolol. And then we're like, you're going to have some end-stage kidney failure because your blood pressure is so high. Here's some labetalol. You don't just go right to labetalol. And she was itty-bitty. Like, she was smaller than me. Like, she was maybe 4'11", 100 pounds soaking wet. And they're like, here's like 100 milligrams. I was like, oh, y'all trying to kill her. You all trying to kill this lady. So, yeah. Moral of the story. Don't do that to little old people. Exactly. Perfect. No worries. Oh, absolutely. Yeah, you can bypass. Especially you go in going, this 100% sounds like it's a beta blocker overdose. You can be like, I'm just going to call medical control. But that doesn't mean that, while you're calling, your partner's not getting a line, you're doing a 3-lead, you're doing a 12-lead. You really should have all of those things in place or in process before you call. Because you still have to, when you call in the city at least, you have to call and you have to get through the medic. So you call, you talk to the medic, you're like, hey, what's going on? Hey, I got a 78-year-old female. They just gave her, she went to cardiologist today, and they gave her labetalol. She took it for the first time, and now she's hypotensive and bradycardic. I want to give her glucagon and glucagon calcium dopamine for a beta blocker overdose. And they're like, all right, hold on. Stand by for the doc. No, they don't give a shit. They don't care. The medics will give you a harder time as a medic than as an EMT. As an EMT, they're like, okay, I expect you to not know anything. As a medic, they're like, but what's the vital signs? And you're like, excuse me. But no, they're rough. They're rough on the medics too, because they were like, you got a line? You're like, yeah, of course I have a line. Well, where's your 3-lead? Where's your 12-lead? My 12-lead, I already sent you my 12-lead. It should be there. It should be 5-1 Victor. Actually, no, I think it says Jamaica Spare today. Like, you sent me 2 different 12-leads, and the first 12-lead got deleted. I don't care, bro. Pick one. They're the same. Yeah, they're tough. The medics are tough, but then you get to the doc, and depending on which docs you have, is going to be what level of aggression you're doing. Like, Hansard, pretty aggressive. Heggie, very conservative. What's her name? The lady doctors are the best. They're like, Giordano. She's like, so what do you want? You're like, can I do this? She's like, that sounds good. Go for it. And, what's the other one? Jacobowitz? Does that sound familiar? There's another female doctor, Jacobowitz, I think. And she's also like, yeah, go ahead. Like, she's like very like, you sound like you know what you're talking about. Go for it. Again, this might just be me because of like the way I kind of approach the call, like the phone call. I don't panic. The number one thing you cannot do is panic. You have to. I'm always bright and sunny, and when I call on the phone, like, hi, it's 5-1 Victor. Like, I'm calling for orders, and they're like, okay, what you got? Well, the patient's in arrest. Like, and they're like, oh, the patient's in arrest? Let me get you the doc. And you're like, okay, no problem. Like, you call like that, and they're like, they don't care. You call like, it's 5-1 Victor, I need to get the doctor, I need orders. Like, they're like, you need to calm down. What's going on? So, it's all about how you approach. It would be the level of receptiveness that you get from the doc. Chalk. Yep, chalk. Or a nice flush. If you can get separate lines, do separate lines. If you can't, that's not a big deal. Other things you should not mix: dopamine and epinephrine. They will also crystallize. However, and I've done it. I've had a post a ROSC, hung dopamine, had to give another epi, but could only get one line of the guy. Locked the dopamine. Don't touch the rollerball on dopamine. It's a pain in the butt. Locked the dopamine. Turned the piggyback, right? Because you hang dopamine piggyback. Turn the piggyback back on. Pressure pushed it through. Pushed epi. Pressure pushed the piggyback line. Started the dopamine back up. No problem, right? The entire way to the hospital. Not a single issue. Get to the hospital, and the bag is labeled. It says dopamine in big freaking letters, right? Because I labeled it. Always label your medications. It says dopamine, right? And I go to the nurse patient due for epi. I'm like, that's dopamine. Don't push it in that line. The whole thing crystallized. St. John's Episcopal. And I was like, so then the nurse comes over. She goes, who hung the dopamine? And I was like, my partner. Why? She goes, because it crystallized. I was like, you better go talk to your nurse, because I told him that was dopamine and your boy pushed epi into it. So don't come at me trying to complain that it crystallized, because we did it right. I managed to push 3 epis on the way to the hospital with that line with not a single issue, because I flushed the line. She's like, oh, well. And I was like, goodbye, sign here. Thank you. So knowing what you're talking about can save your ass too, because like she was one of those people who was going to call and complain. So, all right, cool. Any other questions, thoughts? Zach had a good question. What size catheter shall you use for an EJ? Whatever size you can get. I would recommend a slightly larger gauge, 18 or so. Largest I've managed to get into an EJ was a 16. 16 also happens to be my favorite large bore size, just because 14s are really long. You need a good straightaway to kind of sink it in there. 16s are a lot shorter. Your needle will always, the bevel of your needle will always be pointing to the heart. So if you're in a foot, you're pointing up. You're in an arm, you're pointing in. EJ, you're pointing down. Okay? You're always pointing in the direction of the heart. Best and easiest way to remember it. Great question. Except for scalp veins. We don't do scalp veins, really. But they do it in the NICU. Yeah, for the little babies who, they have nothing. They, put the little thing around their head. And they'll put I think it still goes towards the heart, but don't go there. I hope you never have to do a scalp vein IV. All right, cool. All right, one more scenario, and then go about our evenings. Okay, you are called to the scene of a seizing patient. Upon arrival, you walk upstairs to find a 20-year-old female, heavily pregnant, having atonic-clonic seizure activity. The family on scene states that the patient is pregnant with her first child. Approximately 15 minutes prior to EMS arrival, patient went to the bathroom, stating she was not feeling well. She was in the bathroom for approximately 5 minutes before the family heard a loud thud. The family experienced some difficulty accessing the patient, but when they did access it, she was seizing. Patient has not stopped seizing since they called 911. Family states the patient was told yesterday that she has protein in her urine. Denies any medical history. She is G1, P0, A0. She takes prenatal vitamins, is allergic to penicillin. She has a blood pressure of 180 palp. Respirations are 24 and shallow. Pulse is 128. SpO2 on room air is 88%. BGL is 116, and you are unable to get an EKG secondary to patient movement. What's your initial... Perfect. What are your context clues for eclampsia? Because could it be that she had a new onset seizure? Yeah. Is it unlikely in the current state of pregnancy? Also, somewhat yet. Yes. You don't. Well, I mean, yes, high blood pressure is absolutely a good way to distinguish it. However, if she's been seizing for 15 minutes, she's probably going to be hypotensive. Correct. Okay. First and foremost, before you even worry about positioning her, what's the number one thing you need to do for this patient? Airway. Good. Because now, are you not only breathing for her, but also the baby? That is an atrocious SpO2 for a baby. Okay. What are some of, let's go back real quick. What are some of your context clues other than the hypertension that this patient is most likely eclamptic, other than that in the pregnancy? Okay, good. So yes, she does have edema. And this is also, let's talk about some questions and observations that you're going to look for while you're assessing this patient. So she does have edema bilat lower extremities. Perfect. What else? Yes, protein in the urine. Okay, headache. Okay, so what question would you want to know about how heavily pregnant she is? She's got one. This is her first. This is her first child. How about, let's be a little even more specific. How many weeks? Due date, EDC, and how many weeks? Things that you may or may not know. What they start to do when you get close to your EDC, your expected date of confinement, which is just the most hilarious medical term ever, which is also your due date, is they start to define you as week and day. So a woman might be 37 weeks, 3 days. Okay, just one of those questions, right? So they're like, some people are kind of like, the people who are like, my prince is about to join us, are the people who are like, I'm 37 weeks, 3 days pregnant. And you're like, okay, Karen, walk to the truck. You're fine. Is he coming out right now? No. Stop. So just in case anyone wants to be super specific about just how exactly pregnant she is down to the day, those are the terminologies. All right, so she's heavily pregnant. We've got EDC. We've got weeks pregnant. So this patient is 35 weeks pregnant. Hold on, so airway is a essential item. She has positive edema, bilat lower extremities. She has a positive protein in urine. So going back to why was she complaining? Family stays right here. It's from your medical history. But this is also a great question for you to ask if you happen to walk in, okay? Or if you're even assessing any pregnant patient, right? You should ask, okay, have you ever been told that you have protein in your urine, right? Because you go to some innocuous, pregnancy call, oh, it's a sick pregnant patient, okay? And she's complaining of a headache, and she's hypertensive at 180, but she's awake in ANO3, right? And she goes, hey, you ask, hey, have you ever been diagnosed with protein in your urine? And she says, yeah. You should be like, let's go to the hospital, because, there's a very good possibility that she's going to go from chilling to seizing. Okay? Perfect. All right, so when she went into the bathroom, she was not complaining of a headache, but was she complaining of upper abdominal pain? Other signs and symptoms of eclampsia, preeclampsia, visual disturbances. Rails, right? Good, let's put that up here with edema. Rails. Okay, what else? Good. And where did you find that info, Joni? Good. I do believe that this is also. Hold on. It's also in your protocols. That's what I was gonna say. Good. It should be. Systolic blood pressure of 160 or higher, diastolic blood pressure 110 or higher, severe headaches, visual disturbances, APE, and upper abdominal tenderness. Fantastic. All right, so I think we covered all of those. Now, you have managed to maintain this patient's airway. Congratulations, well done. Okay, how you've positioned it perhaps. How are you going to ventilate her, or are you going to just put it on a breather? Especially, okay, how about intubate? Perfect. Can you give MAG? Okay. So that's right here. So obnoxiously, medical control. And this is one of those calls when you get the medic, you go, "Hi, I have a seizing eclamptic patient. I need the doc for MAG now." I go, "Okay, stand by." That's the one that gets pushed through. Okay? That's the phone call that they're like, "I don't know what you're doing right now, but you need to take this." Okay? So that means that you should also have an IV in place, right? What else? What else do you want to do for this patient? I know positioning the left lateral recumbent is important, right? Because she's 35 weeks. While the seizures are going, your partner is calling. You're getting an IV, your partner is calling. What do you want to do in that meantime? Mm-hmm. Okay, good. It's a very strong possibility you might need to intubate her because you don't know what's going to happen to her mental status after you give her the MAG. Now, what is the definitive treatment for eclampsia? At the hospital. Yes, transport, definitely transporting. Yes. Delivery. How do they deliver? Now, let's have a little complicated morality, legality, protocol twisting conversation. Would you give her midazolam? If you give her IM midazolam, which has about a 10-minute onset, and you have perhaps a 15-minute transport time to the hospital where they will be delivering this baby immediately and have NICU response, would you hesitate for midazolam? If you were on hold for that one time that the city's blowing up and you're on hold for medical control. Exactly. Okay, how would your answer to this question change if I told you that this was a 35-week pregnant female with a history of seizures? You can say sat up because that's tough. How would you be able to determine with a patient who has a history of seizures if she is eclamptic or just having a breakthrough seizure? Because now remember, patients who have a history of seizures, a lot of those medications, if they do become pregnant, are not safe for the fetus. So they will change their seizure medications during pregnancy to protect the baby. Exactly. Exactly. Yes. So hold on. So let me pull up the seizure protocol for everyone. Maybe if I can. Well, seizures also tend to be a relatively sudden onset. I mean, if you have a patient who literally just had like a medication change because of their pregnancy, they might be having a breakthrough seizure, or it could be preeclampsia. In that moment, I think this is the question that I'm really kind of asking. Hold on, let me just son of a bitch. In that moment, when you walk in and you see a 35-week pregnant female seizing on the floor, and you know that you have to call, not only do you have to call to get permission to give MAG, but you also have to start an IV, protect the airway, keep the family calm. Would you give her midazolam to try to break the seizure while you're waiting to get magnesium? Or would you continue to let her seize and hope to ventilate her appropriately? I'm saying you have wiggle room, and this is where that critical thinking is going to kind of be effective, or most effective, is if you walk in and you say, hey, she's seizing. Hey, I don't know if this is new for her. I don't know if this is clamsic or preeclampsic. I know that I'm going to have to give her MAG one way or the other. But if I give her midazolam, will I give her and the baby a better opportunity to be oxygenated and have proper airway control? Maybe you want to do it, right? Because if the ultimate treatment for this child is that they're going to be, or for this situation as a whole, is that they're delivering this child via emergency C-section, when they get to the hospital, can they do neonate resuscitation if the baby is depressed because of the midazolam? Can they give them flumazenil to block the midazolam? Can they control the airway? Can they keep the baby warm? Can they do all of those things that might be required? Because again, now 5 milligrams of midazolam is not a significant dose of midazolam, especially if you're giving it IM. Not significant. The amount of time it's going to take for that medication to cross the placenta, the blood placenta barrier, is considerable. The amount of time that you're on the phone for medical control asking them to give you magnesium could also be considerable. Most of the time it's not. Most of the time they're like, okay, cool, no problem. But could it be that you happen to call that one day that there's 6 cardiac arrests and there's, a drowning baby and there's, a fire in the Bronx and like everything's like just exploding? It happens. There's only one doctor, one medical control doctor for the entire city of New York at a time. Or you don't even have to go that far. We walked in, patient was seizing. She's 35 weeks pregnant. We have no idea if she had a seizure history or not. We gave her 10 milligrams of midazolam. Called medical control. They gave us 2 grams of mag, and we're here. Because 2 grams of mag is also minimal. The initial loading dose for mag in the hospital is 8 grams. That 2 grams may or may not touch that seizure. And if as long as they know that that baby might be depressed secondary to midazolam administration, then they know what they need to do. But if you keep it a secret, they're not going to know what to do. But you walk in and say, patient mom, mom was seizing. We controlled the seizures with midazolam. We gave her mag. Maybe she's seizing, maybe she's not still. Well, we controlled the airway. We ventilated her as best we could. That's the optimal outcome that you're going to have, is that you've ventilated and oxygenated appropriately. And that's going to be a backup, another call to medical control. And they're going to decide what to do. Because mag is one of your volume over time medications, right? So you're putting 2 grams in 100 milligrams. So you're giving it over 10 to 20 minutes, which 100 milliliters over 10 minutes is a macro drip on wide open. So you let it go, and she's still seizing. You might have to call and say, patient's still seizing, can I get more mag, or can I get a discretionary order for midazolam? Because they do use benzos in the hospital for eclamptic patients as well. Because again, ultimately the treatment is that they will be delivering the baby. So the exposure to the benzos will be limited. Probably relatively quickly. I mean, if she's not necessarily. Not necessarily. Midazolam sometimes, some people it works really, really well on. Some people it doesn't touch. Sometimes when you give midazolam, they will actually just come out of the seizure and like kind of wake up. And you're kind of expecting them to be like totally out, and then you're like, oh, they're awake. I have to talk to them now. Okay, we'll chit chat. But then some people who just out cold. I had one lady once who started hyperventilating, and I was like, "You're not supposed to do that. What are you doing?" That was really funny. We got called for. Oh, I'll tell the story at the end before we go, but remind me. But yeah, so you may or may not have a patient whose I guess respiratory drive is depressed enough, and with midazolam, with that level of dosage, you're probably not going to see it that much, but you could probably. 100 per now. Etomidate. Definitely use the etomidate. It's just easier. I don't think I've ever had a successful tube with just benzos. It just doesn't knock people down enough. Yeah, they give you the option. And you're like, oh yeah, that sounds good. Like, why would I want to I don't want to paralyze them. Let's just like put them to sleep. It'll be good. They won't remember a thing. And they're like, I'm still awake. And you're like, why? No, you'll have time. You'll have time. You'll have time. Because you can also manage the airway BLS style, right? As long as you can position the airway and you can get a good ventilation with the BVM, you should be okay. Remember, BLS before ALS is always what you're gonna need to do, and keep that in mind, because this is why ALS providers kill trauma patients. That sounds weird and horrible, but basically what happens is they get so excited that I'm going to start 2 large bore IVs. I'm going to I'm going to do this. I'm going to do that. No, trauma, just splint, stabilize, go to the hospital. If you can get an IV, fantastic. Maybe do it en route, but do not, dawdle on scene because, your protocol says that you should get 2 large bore IVs. Also, as y'all start in rotations, definitely find the spare large bore IVs and keep them in your pocket, because you're going to be, trust me, you'll get the trauma call and you're going to go, I've got a 14, I'm doing the IV. It will happen. And they will go, well, you better get the IV. So, they did an immediate delivery. Mom and baby were fine. I was working with Lala. We walked in, and I think I'd never seen Lala's eyes get so big, because he was like, oh shit. And I was like, damn it. She's very pregnant. And I hit her with midazolam. Lala, call. Just call. I'm hitting her with the midazolam because, she was seizing for 15 minutes before we even got there. So I was like, this seizure needs to stop. So I hit her with the midazolam. It slowed the seizure down. We got the mag. We ran the mag. She was not seizing by the time we got her. So downstairs, got to the hospital. She started to desat. She was breathing actually quite well until we pretty much rolled into the ER, and then she started to desat. And they're like, let me tell you, OBGYNs are not designed to be in an ER. It's just sheer panic. They're like, oh, you're like, okay, calm down. She okay. She's got line. She's got oxygen. She's good. She's chilling right now. Maybe get some fetal heart tones, because, I'm not trained to do that. But I felt the baby kick a little bit. I think she might have gas. Who knows? And just go deliver the baby. And they're like, oh, this poor woman was on a non-rebreather. And they tried to wheel her to the OR, and it was still attached to the wall. They damn near decapitated her. It was preeclampsia. Oh, good. Yeah, I got plenty. So as promised, I was working. This is the day at Jamaica where all of the diazepam was used. The last of the diazepam. 5-1 Will got a job for this guy who was I forgot exactly what the call type was, but he was unresponsive. And Michelle Cruz was on the ambulance, and she was 8 months pregnant at the time. So we were all hyper aware of that, and we're like, we're going to go help her. So we went over there, and we're like, all right, they already had the patient out. And I was like, okay, so I opened the back of the ambulance, and they're trying to intubate this guy. And I was like, how's it going? And they're like, he's clenched. Because I don't remember what happened exactly, but his whole jaw was clenched. And I was like, did you give the diazepam? They're like, no, we didn't intubate him yet. I'm like, give him the diazepam. It'll loosen him up a little bit. So they gave a diazepam, and they still couldn't get the tube. So, documentation. Got the tube, lost the tube. But we gave the diazepam after we got the tube. Documentation. So while we were there, 5-1 Victor, go back up 4-7 whoever in the Rockaways. It's pouring out. And I was like, okay, what are we backing them up for? The pain management. I was like, you must be shitting me right now. Okay, tell 4-7 whoever, we're probably about 25 minutes out. Distance, weather. Okay, no problem. So we go trolling down there, lights and siren, right? If y'all working in Jamaica, you will most likely get redeployed to the Rockaways at some point. It is a long journey down to the Rockaways, but it's very nice. It's very peaceful, especially if you're in no rush. But when you're trying to respond to an emergency, you're like, are we there yet? No, we're still not there yet. We're still going. Okay, cool. Are we there yet now? No, we're still not there. Oh, bird. You go past the wildlife preserve. You're going over the Jamaica Bay Bridge. It's down there. Okay, so we finally get there. And it's at this apartment building. And as we're pulling up, mind you, this is almost a half hour later. We're pulling up, and there's 4-7 stupid pulling this patient out, and the patient's going like this. And I'm like, is she seizing? And they're like, no, she's wincing in pain. And I'm like, that's called a seizure. Oh, how long has she been doing that? Since we got here. You're telling me this lady's been seizing for like 35 minutes. No, she's not seizing. She's just in pain. Put her in the ambulance, please. So we hit her with the 10 of midazolam IM. But as we hit her, like the needle goes into her arm and she goes, oh yeah. And I was like, did I just sedate the Kool-Aid man? Like, what just happened? And I was working with Tiffany before she became a supervisor. And our medic student was Christina McDougall. Christina goes, we all look at each other and go, did she just go, oh yeah? We're like, oh yeah, she totally just went, oh yeah. So we're like, that's just not normal. So we're watching her. All of a sudden she goes from, like, so she's not seizing anymore. But now she's hyperventilating and belly breathing. Like, her whole abdomen's going. And I was like, that's also not normal. Like, what happened? So 4-7 useless is like, oh, well, her husband says that he last heard from her. It's like 9 o'clock at night. Husband says he last heard from her at like 2 o'clock in the afternoon. She wasn't feeling well. She spent the day in bed. Okay. He came home and she was laying on the floor next to the bed and she has like a hematoma on her head. So it looks like she fell out of bed, whacked her head on something, and like thinking she's having a seizure now because of a head injury. My ass, 1, don't want to go to St. John's Episcopal. 2, don't want to get stuck in the Rockaways. So I call medical control. I'm like, hey, med control, question. Can we go to Jamaica, rule out trauma? This lady's seizing for over a half hour. We midazolammed her, or we midazzled her, and she is now hyperventilating. So we'd also like to tube her, please. And they're like, yeah, that's a great idea. And I was like, okay, good. We're going to start going to Jamaica because we're now, again, like a half hour away. Let's just drive back up. So we're in back of 4-7 Stupid's truck. We're like, all right, cool, let's go. We're going to Jamaica. They're like, why are we going to Jamaica? Just drive. Don't ask questions. Just drive us to Jamaica. So we're going. And we hit her with the etomidate. And she doesn't loosen up. And I'm like, oh, no. So we're trying to go. She's got this little tiny mouth. We're trying to tube her. I'm like, give her the diazepam. Because we got orders for the diazepam afterwards. So we give her the diazepam. And we got the tube. And then we lost the tube. I was like, son of a bitch. So that was the day that Jamaica no longer had any diazepam in stock. Both of which were my fault. Sorry. So yeah. So we ended up going there. I actually didn't have the ability. Yeah, they were BLS. I did not have the ability to follow up on this lady, so I don't know what actually happened. I just know that was the strangest response I've ever had to somebody getting midazolam. The midazolam was going, oh yeah. And I was like, all right. Yeah. I mean, I've had other scenarios where we walk up and this guy's seizing. Oh, how long has he been seizing? Like 10 minutes. Okay. Hit him with a midazolam. You do your full patient assessment. Turns out his blood sugar's 12. Right? Are you going to check? Are you going to be able to fix his blood sugar before you stop the seizure? No, because the seizure is impacting his breathing and airway. So if you look at it in that sense where now that seizing is becoming a life threat because his airway and his breathing are compromised, it makes a little more sense in terms of how you are going to order your patient treatment, patient care. Oh, absolutely. Absolutely. Cool. All right, guys. Any other questions before we wrap it up for tonight? Oh, yeah, actually, I saw that. Sorry. I don't have a good answer for RSI because I've never actually had the opportunity to RSI. As far as I know, don't third watch me. Kyle's third watching me in the background. As far as I understand it, you use a true paralytic, which is like the acetylcholine, and then you pair that with a sedative to kind of keep them calm and relaxed. RSI is a little scarier than what we do in the city with the etomidate and the midazolam is considered medication-assisted intubation, as opposed to RSI, which is rapid sequence intubation. Rapid sequence uses those paralytics, while etomidate is a hypnotic. Okay, so that's kind of where that line of division is. Where your paralytics, you are in charge of that airway. You are breathing for that patient until you get a tube in place. And then you're still breathing for that patient, but now at least the airway's secure. When it comes to etomidate, you have about a 60-second window before it wears off, and the patient potentially will just come back and be like, "What are you doing to me?" And you're like, "Nothing, lay down again." Etomidate, if you push it too fast, you will clench the patient, that you will create lockjaw. Depending on which kind of paralytic you are using, what's the word? Fasciculations, right? If it causes fasciculations or not, you can pump it as a little bit faster, just because it doesn't have that same effect. I don't know if I can. Honestly, I would say when you go to Empress, ask those medics, because they're going to be much more familiar with it than I am, because I've never worked in a system that allowed RSI. No problem. In order to intubate, yes. Yeah, so I think that hold on, I'm gonna wipe, oh, that's not it. Let me pull up the whiteboard and do a little drawing for you guys, because I know some people like to, whatchamacallit, to see. I know some people are visual learners, so let's visual learn a little bit. So if you are, right, so you have, oh, I don't like this color at all. Right, so you have airway, breathing, and your circulation. So here in your airway, you have the head tilt, chin lift, you have the jaw thrust, you have OPA, NPA, and really, as like you're moving down, right, it's getting a little more aggressive, and then you have an ET tube. Right, because remember, you do your scene safety, BSI scene safety, number of patients, mechanism injury, nature of illness, additional resources. I'm going to consider C-spine, and then like, okay, now I'm going to go to my airway, right? So I'm going to do a head tilt chin lift, or if it's a medical patient, I'm going to head tilt chin lift. If it's a trauma patient, I'll jaw thrust. Does the patient accept an OPA? And then you're kind of in this like line, like in between airway and breathing, where you would consider intubation. Because when you get to breathing, right, so it's I pass gas. I don't know, some people learned it differently. Or I passo, right? So you're going to inspect, palpate, auscultate, seal and stabilize. Beautiful. And then you're going to give oxygen, right? So when we say, oh, on this, my multiple choice, am I going to intubate or am I going to give oxygen therapy? Intubate's kind of up. Oh, I changed that color. Intubate's kind of up here. That is not helpful at all. Where oxygen's like all the way down at the end of breathing. Does that make sense? Where if No, it's that's I think kind of the difference where we're lying, where the difference lies, is the kind of nitty gritty, formulaic test question, where in reality that patient, you slap patient on that you slapped oxygen on that patient before you even really know what the nature of illness is, right? Like, you walked in and you see this patient's breathing like crap, and you're going, "Hi, I'm here to help. I'm in the ambulance. Here's a non-rebreather. Like, is this helping your breathing? What's going on today?" You're listening to lung sounds. Like, we don't follow that linear flow in real life, but on the test, you have to kind of do that obnoxious step by step. It's not even time. It's not even time. It's just that intubation is considered an airway procedure. That's literally, it's the semantics of it. Jody, what were you saying? Sorry. And that's one of those questions that, like, if I was a test maker, I would be like, I don't like this question at all. Like, this question is not valid. It's not testing your knowledge. It's testing your memorization of these steps that in real life you're not going to follow 100% just like that. You're going to have a variation based on what your patient needs. Or if you see and it's like, oh, life threat. Okay. And Scott will argue with me like, oh, airway's a life threat. You have to control the airway. Are you telling me that I can't control this airway via BLS maneuvers? Suction is an airway procedure, right? So you're telling me that in this test scenario where I have very limited information, that I should just jump right to intubation. Like, I have no information on this patient whatsoever. I might have the opportunity to get a little bit of history for them before I stuff a tube down their throat, and I should just do it. Just go with it. Just right down, right? Like, personally, I think it's a crap test question. That sounds like it, yeah. All those little memes about the National Registry, it's like, you called to the scene of a clown car accident. How many oranges are there? That's totally right. Like, a lot of them is just like, what? You don't feel like you necessarily have enough information. Joni, when you take the ALS update, or the ALS upgrade exam at Jamaica, this is what you're in for. Start kissing ass now. Those are ones that are currently in effect in the city. The ones that I gave you were supposed to go into effect in August when you guys were going to be doing your ALS rotations, but COVID. So it pushed back not only the protocols, but you guys' rotations. You're right primarily in Westchester, correct? Ben? Okay. Well, I'm just saying, if your primary job functions are going to be in Westchester, I would say maybe look at those. They're probably very, very similar because I think Westchester already moved to the collaboratives. So it's probably not wildly different. It might just be different colors. All right, guys. Any other questions? You're very welcome. All right, we'll do this again next week. We'll have to come up with some good jobs. All right, good night, guys.